Hello, and thank you very much for joining us. This is the CTSNet roundtable discussion happening at the EACTS 2018 in Milan. It's a beautiful big meeting which many topics are being debated and discussed, all at the frontiers of scientific innovation and evolution. And for this particular reason, we have planned out for you a nice topic. It's a bit controversial topic. It's on device technology and engineering. It's a frozen elephant trunk. Is it a clinical or a personal equipoise? And for this particular reason, I've invited to this session the giants on frozen elephant trunk across the continent. To my right-hand side here is, as you all know him, Malak Shrestha from Hanover in Germany. Next to him is Konstantinos Statsakis from the world-famous place Essen in Germany. And on my left-hand side here is George Mascaro from Queen Elizabeth's Hospital in Birmingham. And also to my left-hand side here is Davide Pacini, who is the chairman of the vascular domain of the European Association 2018. Thank you very much for joining us today. So as we all know, this frozen elephant trunk has been introduced in 1996 as an evolution for the conventional or the floppy elephant trunk, which was introduced by Hans Borst back in the mid-80s. Now, obviously, that was to shorten the duration or to sort of like render it from two-stage procedure to a one-stage, any sort of like pathology involving the arch and the distal stream of the aorta. However, till today, there has not been a robust evidence on the use of frozen elephant trunk. We've done similar to the audience. We've done similar sort of a debate back in 2015. At that time, we had Professor Roberto Di Bartolomeo and a group of from Martin Czerny and Malak Shrestha was also at that time with us, and Ruggero Di Paulus, who's the vice president of the European Association. At that time, we listened to that particular session, and it was interesting. Now, moving on, 3 years down the line, I don't think much has been changed since. Although, I would like to start with you, David. Do you think that anything's been changed since frozen elephant trunk has been introduced up to current date, before we dive into the different types of frozen elephant trunk? David.
Well, let me start saying that I think that during the last 2-3 years, some technical details are improved. And I mean that I think everywhere in the world, in the center where the frozen elephant trunk is performed, in every center, there is a trend of doing the distal anastomosis more proximal. So, and I think that this is the major changes during the last 2-3 years regarding the technique of the frozen.
So venturing into the distal part of the aorta with the use of a frozen elephant trunk?
No, to proximalize the distal anastomosis in the heart. This means to make easier the distal anastomosis and to reduce the time of the deep circulatory arrest time.
Okay, excellent point, David. I'm going to move this particular point to Malak. Malak, we all know Hanover, yourself. You've published a lot on the frozen elephant trunk, in particular the Thoraflex, which is device and engineered by Vascutech. What do you think has evolved since you started? Not your surgical skills, the device engineering, the device innovation.
First of all, I think I have to contradict you when you say that there's no evidence for the efficacy of frozen elephant trunk, because there has been clear evidence now, both from the Evita trial registry, that both Davide's group in Bologna and Konstantinos in Essen have been publishing, and also from the Thoraflex also it is very clear. But one should not expect that just because we put in a Thoraflex or a Evita in with the frozen elephant trunk, it's going to be a one-stage procedure. It all depends upon having the correct patient for such procedures. If you are taking the wrong patients, of course, it's never going to be a single-stage procedure. With the classical elephant trunk, which you correctly said, that evolved from Hanover in the 80s, it was never a single-stage procedure. There always had to be a second-stage procedure with classical elephant trunk. The only thing was it made the second-stage procedure easier. With the frozen elephant trunk, if you choose the patients correctly, if at the landing zone, if there's a tight fit in aneurysms, it's going to be a single-stage procedure. And also in the acute dissections also, if you do the frozen elephant trunk, then there is a remodeling of the descending aorta, the dissected descending aorta, and you turn that into a single-stage procedure. You never have to operate again on the arch because it's not going to dilate, which is the case when you do a classical repair with only an ascending replacement in an acute dissection. So the evidence has been clear. There is a misconception, I think, in some people that if you do frozen elephant trunk, it's going to be a single-stage procedure. It's not. If you choose the right patients, then yes, right? So if you choose the wrong patient, if the aneurysm is going right down to the iliac arteries, it's never going to be a single-stage procedure. So that's one thing is very important. The second stage, now with the new technical innovations, like over the years, I think, like David has said correctly, that we've evolved. We've learned a lot of things, and we learned that if you proximalize the distal anastomosis going to the zone 2 instead of zone 3, one is that it's easier to do it for the surgeon. The second is that there's less chances of neurological damage to the recurrent laryngeal nerve. So these two are positive things, and that has, I think, one of the things that most of the centers now moving from the zone 3 to zone 2. I myself also started with zone 3 because that was what we were doing before, and now we are doing zone 2 in almost all the patients, unless there is some reason not being able to do it. So that is a big technological advance. With the devices itself also, there has been changes in the last 3 years. Evita has evolved a little bit also. Also with the Thoraflex, we've got now Gen 2 instead of Gen 1. So there is also a little bit of innovation. So I think there has been changes in the last 3 years. And we've also had now thousands of more patients in these last 3 years. So we have more evidence also.
Good stuff. So I've picked from your point here, patient selection. So George,
I think.
Yeah, sorry, you want to say something?
Yes, if I can say, I think we have also grown in confidence in what we can achieve with the frozen elephant trunk. And from that point of view, the changes are evident as well in terms that we are being more aggressive in the type of patients that we are selecting.
Excellent point. So we're going to go back to patient selection because we spoke about technical skills of a surgeon, the confidence we build, the evidence that Hanover or Malak pointed at. I'm going to pass on the question to you, George. Patient selection. Do you think you are appropriately selecting patients, or is it the patient choice? He knows or she knows what they want, what they need. We've discussed this off air together about this. What do you think?
No, I think it's not necessarily a patient choice. I think we are the professionals, and we know the pros and cons of the procedure. We need, however, to have appropriate consent from the patient. We need to explain to the patient the pros and cons of having one procedure or not having that certain procedure. And then perhaps even if we know now that we have, as what was being mentioned, mainly 2 devices that are widely used, although both devices have not been compared. But as Malak was saying, there is evidence that both devices can be used safely, and that needs to be explained to the patient.
Okay, good stuff. Kostas, patient choice, we've touched base on it. Hanover, giant experience. Malak, technical skill and the confidence and the, venturing into different zones. What are the indication of using frozen elephant trunk? Let's put it as a wide title. What's the indication in your own experience? Because so far, I've not seen any paper, Malak might not like this, that really instigate that those are the robust indication. Okay?
So in our experience, the main indication, I see 2 indications.
Yeah.
The first is the Q-type 1 aortic dissection that we can perform with a frozen elephant trunk to treatment safely, since the anastomosis in the zone 2, which is approach that we described 2012. and can be performed easily and fast. And we have the hemostatic advantages of the stent graft in the proximal descending aorta. And we know in the acute type 1 aortic dissection that you can achieve exclusion of the false lumen up to the obliteration, up 90%, 94% of the patients. And these are results also from our center, but also from the International Evita Open Registry.
Excellent, good point.
The second case is the aneurysm situation. If we have patients with aneurysm formation in the distal arch or proximal descending aorta with a good landing zone distally, then we can treat them 100%. We don't have endoleaks in these cases. Now, if we have another point, we look to the chronic dissection, chronic residual dissection, 1B, whatever, or thoracoabdominal aneurysms. Then, as Malak said, we have to plan the treatment as first treatment first, but probably also as a second treatment can follow. And therefore, if you plan two-stage procedures, then you can decide to use a classic elephant trunk or frozen elephant trunk. However, also in this case, I would prefer the frozen one, since we have the procedure is the stent graft is longer and stiff, and we can have a better landing zone for secondary TIVA, or also even open surgery. We have not to clamp in the arch, close to the arch. We have to close the mid-descending aorta for secondary open surgery. So I would say acute type 1 dissection and aneurysms in the distal arch are clear indications of frozen elephant trunk, and the other is choice of the surgeon. I will choose frozen elephant trunk.
Surgeon. Excellent. This is an excellent point, Konstantinos. So, Malak, no robust indication or robust indication. Konstantinos touched base on the pathology and then surgeon's discretion. What's your take on this?
Well, I would say that it's not surgeon's discretion because there is, for me, a robust indication. Like I said, in acute dissections, for me, of course, that everyone says that you have to do the simplest and quickest possible operation to save the patient's life. That is okay for, let's say, small centers. But if you go to the bigger centers where you can offer the same results, but gives a longer, better long-term results, then why not? Yeah. And in type 1 dissection, when it's not enough to say in acute type A dissection, in type 1 dissections, if there is malperfusion, whether you put in a TIVA or if you do only a proximal repair, it's not going to treat the malperfusion. So one has to put in a stent in the descending. You can put in a EVA, or even better is that, do a frozen elephant trunk.
Yeah, but sorry, Mark.
Yes, David.
Do you mean that every kind of type 1 acute aortic dissection has to
be?
No,
in malperfusion.
Perfect.
Only in malperfusion,
okay.
I said.
Good.
That's the only place where there is a clear indication. Perfect. And maybe, but it is very rare, there's a rupture of the distal arch. This is maybe 1%. And there also maybe there is a clear indication. In the rest of the type 1 dissection, of course, I would not do it because there is no clear indication that it's better than doing a proximal repair. And especially in the younger age group, yes, I would do it because it makes the second stage procedure, which we know will happen in type 1 dissection, a lot easier.
I think that's what Malak is saying is absolutely right. I mean, and that's what I meant with we have become more aggressive and more confident in our indications, in that we believe, and slow the evidence is coming. We still need to see what time is going to tell us.
That's true.
But we have grown in confidence in that probably with the elephant trunk we might be able to simplify with frozen elephant trunk. We might be able to simplify any further procedures, and maybe, as Malak was saying, the patient may not need a further operation in the future.
Okay, let's dissect the words of confidence and surgical dexterity or skills. Okay, let's dissect this further. Malak, in 2015, you mentioned on a CTSNet roundtable, which was viewed by many people, that you would also go for a chronic dissection. And then there was a little bit of controversy on the panel with regards to a Marfan patient and the age.
No, at that time, I said that I'm not 100% sure in chronic dissection, like I was sure in acute type 1 dissection in these special cases or in aneurysms. That was early part. Now we know, in these last 3 years, we have more evidence that even in chronic dissections, like Konstantinos said, that there's a clear indication that frozen elephant trunk is better than classical elephant trunk, because in classical elephant trunk, what we used to do in Hanover was that cut the false lumen, putting it in, and you needed a quick second stage operation. With the frozen elephant trunk now, you can put it in. They will be remodeling at least on the upper part of the descending aorta. And like Constantino says, one did not need to go and clamp in the distal arch. Now you can do in the mid, you start in the mid descending, which is a lot easier.
So what's your take on chronic dissection?
Even
and
now,
Marfan?
in Marfan, yes, we
Okay.
do a frozen elephant trunk.
Yeah.
But in chronic dissections, depends upon whether the patient has been operated in front or not. If the dissection starts in the distal arch, I'm not putting in a frozen elephant trunk. I'm doing the classical way, the left thoracotomy and replacing from the distal arch up to the, whether it's a descending or a thoracoabdominal in one shot in deep circulatory from the left side now. Because usually Marfan patients are young and they are fit, so they can, then it's also one stage operation instead of two.
Okay, let's put the indication aside. Let's put the confidence and surgical dexterity aside. Let's bounce it with the £1 million question. Davide, Bologna, big center, loads of experience between yourself and Professor Roberto Di Bartolomeo. On both ends, frozen elephant trunk is an excellent choice. Malak is saying here that it has a robust evidence. He's actually criticized my point that there is an evidence for that. You've used both device technology. Konstantinos, watch this. Which is better?
I cannot say.
No, Davide, which is better? Is it the Evita or is it the Toraflex? I have an evidence for that. I'll put it out for you to help you, but I just want to hear your point on this.
My point is the right graft should be right for the right patient.
Excellent.
So you cannot compare the graft between both, because one graft can be the best for that patient and the other one for the other. So what in Bologna we do is that we use most of the time the Evita graft for the chronic aneurysm, because we feel more safer about the stent graft, the distal stent graft sealing, and we feel very comfortable with that. And we prefer to use the Toraflex in acute dissection.
You prefer to use the Toraflex?
Yes.
Okay, Konstantinos, your turn.
Yes.
He prefers Toraflex. George, we're going to come to you in a second.
No, sorry.
Sorry.
I prefer the right graft for the right patient.
You said I prefer the Toraflex. We
For
prefer
acute
the right
dissection.
patient. Okay,
For acute
Konstantinos.
dissection.
Konstantinos, amuse us. Talk to us about the Evita. Where do we stand now with the Evita? I know that there is a new complex, new device coming in.
Now,
we all
believe-
hear it.
we started and we believe on the Evita actually due to the had the advantage of the stent graft, it's an endovascular technology, and we know what we have to do to deal with endovascular technology. And in all cases, aneurysms and dissections, we can decide, we can size the stent graft very well, and we can. And a further advantage of the Evita is for me personally, the tube configuration.
The Evita.
Is the tube configuration.
Listen to this, yeah.
Since we have the option, the tube configuration allows us to land the distal, to decide for the distal landing zone. We can go deeper, or we can stay more proximally, depending on the proximal fixation, or we can introduce the stent graft more deeper using the angioscopy and to exclude the pathology as we wish. And the stent graft itself is an endovascular stent graft. It has and therefore we trust it and we use it. But and to be clear, I don't have something against the Toraflex. Of course not. We have the practice with Evita Open. We have excellent results with this, and we use it. This is the reason.
Hold your fire, hold your fire, hold your fire.
No,
Malak,
I would say
just for a
differently.
second.
I mean, I'm one of the few like David that was used both the grafts. So we have used a lot of Evitas also. I have only one problem with the Evita, that is the delivery device. From what we published, a lot of 15-year results, 10-year results in last 5 years, and in both the papers, I said that both the grafts in the long term behave similarly. There is no difference in long-term results. The only difference is that to implant, during the implantation, Evita is a lot more difficult because actually the implantation device is actually made for endovascular thing and not put it through the open aorta. That's the only difference. Otherwise, for me, actually, there's not, in the long term at least, because our results have shown that there's no difference between the long-term results with the Chavan Harvest, which was the first prefabricated one, or the Evita, or the Toraflex. It's more or less the same.
Okay, so David said select the right patient. You're saying there's no difference. He is saying Evita has more advantage. George, Birmingham.
But I have to correct. He has never used the Toraflex, so he doesn't have any experience with the other one. We are the ones who have both used both.
We know how our patients are doing. So from our experience, we are we know that the Evita works very, very well.
Okay.
And I don't say that the Evita works better than the Toraflex. This can answer the Malak definitively better than I. But in our option, as the result from the Evita open patients is excellent with regard to exclusion of the pathology in durable situation.
Clarification. George, you mentioned, before we touch base on this, you've mentioned the word confidence. Don't you think that because of confidence in using the frozen elephant trunk now, and we moved from the conventional elephant trunk, that it's played a little bit, this is a biased factor. Just because we gain confidence, we are supporting Toraflex. What do you think?
No, I'm not saying. I'm not saying that because of confidence we're supporting one or we are supporting or we're supporting the other. I think if you really want to find out if one of the devices is better than the other, or if they perform different, then you need a randomized trial, and we need to look at it scientifically.
Okay.
I do use both.
Yeah.
And I probably have a similar approach to what the Evita does.
Yeah.
I think in the acute setting, the Thoraflex is a much better graft. Radial force probably is much easier. Thoraflex has got less radial force and gives me more confidence in the frail tissues.
I think you have to say the implantation. That's the only difference.
Give me more confidence. Surgeon discretion. Constantinos, what's your take on this?
If I agree or not,
yeah,
I don't have the experience with the Toraflex, but I cannot imagine that has more radial forces than the Evita Open. I can say
less.
Less. But in this point, with the Evita Open, you have the option to decide about the size of the graft, and you know how the graft will react. You know it's from the endovascular procedures, how the stent graft will react in acute or dissection, and so we can precise definitively how it looks like. If the Toraflex provides the same results as stent graft with the Evita Open, I agree. Okay,
no,
but we don't know it.
We know that because we have already published our 10-year results also. We know that the results are the same. I'm saying that the only difference is, because I've used both, is the implantation. When doing implantation, the Toraflex is easier than the Toraflex.
I think again, back again to the randomized trial. I think it's necessary to draw conclusions, because you cannot say from an observational study that one is better than the other.
No,
because you are selecting patients.
Observational single center studies.
Exactly.
No, we've never said it's better. We've always said that results are the same.
Okay, let's stay on this thought. We did a meta-analysis, which is the foundation for many randomized controlled trials today, between both devices. Okay, I cannot disclose the actual results, but I can tell you the broad titles. The Toraflex came out as better than the Evita in terms of outcome, quality outcomes, in the setting of an emergency, non-elective cases. The Evita dominated the quality outcomes in terms of mortality and morbidity, and also rate of stroke, because the Toraflex had more rate of neurological deficit. Maybe it is biased because we use the Toraflex in an emergency setting. What do you think of this evidence that was just discussed?
I think this is wrong to look at these, because perioperative ones, it's dependent on the perioperative operation and the factors. The only difference we should be looking at, what is the evidence for, let's say, the thrombosis of the false lumen? How quickly, which device does it quickly? That in the long term should be looked, actually, not the short term, because whether if you do any frozen elephant trunk in acute dissection, you are bound to have worse results than in elective cases. So that's different. I think you should be looking at the long-term results, how quickly the thrombus formation is there, how quickly there's a remodeling of the aorta. That's the point you should be looking with both the devices.
But we just looked at what the evidence so far.
No, after the patient
published.
leaves the hospital, that's what you should be looking at, I think.
Okay.
Do you agree with that?
We have to conclude. This is an excellent discussion, which is definitely beyond this debate. The preparation for tomorrow is best done today. Are we doing what is best for our patient? Davide, finish it off.
What I can say, I don't know. What is the best for...
You don't know?
No, I don't know.
Okay. George?
I think we need to gather the information, we need to collect the data, and we need to openly present the data, what every center is achieving, and that's how we prepare the future.
Excellent.
And to make future decisions.
Excellent. Mala.
I definitely say that we are doing now correctly because after that we have the frozen elephant trunk, our
Toraflex?
rate of whatever frozen elephant trunk, I would not say that one graft or other is better because our results show that the long-term results are the same. So the only difference for me is the implantation technique. That I had been saying the same thing for the last 10 years. So I'm not going to change that because our results show both are equally good. The only thing is that it has now allowed us to treat more patients. Before we had the frozen elephant trunk, whichever graft we are talking about, we had to go for two-stage procedures. Now we can do a large group of these patients as a single-stage procedure, and also in acute dissection, we have been able to prevent a redo arch operations in a lot of these patients if we are doing a frozen directly during the first operation. So this is a big plus for me.
Save the best for the last.
I agree with Malak first, and second, I can say the most that we learned from frozen elephant trunk is how to improve our surgical skills. We had to face new problems with paraplegia. We have improved the protection of the spinal cord, the perfusion of the system during the surgery, and also, sorry, we improved our endovascular skills also.
Yeah.
As cardiac surgeons. And this, I think, the frozen elephant trunk is an additional option to go to think endovascularly in order to treat the descending aorta. And I think the frozen elephant trunk is the future, or opens the future to us, to the endovascular procedures.
Evita?
Say, I have the experience with this. How can I say? Don't say it. I cannot.
Listen, this has been fantastic, and thank you very much for being all with such a sport mood today. We leave the final message for you guys to take home. Is frozen elephant trunk a clinical or a personal equipoise? We've seen the giants, whether it's on personal level or it's on the center level, discussing the entity, the skills, the confidence, the outcomes, and the robust evidence that is out there. You've been with Mo Bashir for the Aortic Portal, CTSNet. Thank you for joining us.